Hello everyone, welcome back to this series of lectures on cardiology. In continuation with the valvular heart diseases, today we will be looking at aortic valve disorders and the first one being aortic stenosis. Okay, so before we move on to aortic stenosis proper, let us look at the structure of the aortic valve. So as you can see here, what is the aortic valve? It is the valve which is basically present between the left ventricle and the aorta. So the aorta, as you can see here, is a tricuspid structure. The aorta, as you can see here, is a tricuspid structure. So, what is the normal aortic valve area? The normal aortic valve area is 3 to 4 centimeters square. So, whenever the surface area of the valve decreases and when there is a decrease in the orifice of the aortic valve, that is when you call it as aortic stenosis. So, what is severe aortic stenosis? When the valve area is less than 1 centimeter square. So, when the valve area is less than 1 centimeter square, that is when we call it as a severe aortic stenosis. So, let us look at some of the etiologies of aortic stenosis. So, congenital, the most common cause of aortic stenosis is your bicuspid aortic valve. So, can you see here that there are only two cusps? There are only two cusps, which results in a bicuspid aortic valve, and this results in AS. Okay. Second, acquired cause. It can be because of degeneration. This degenerative cause is what we call as aortic sclerosis. So, degeneration can result in an acquired form which is called as aortic sclerosis. But what is the difference between aortic stenosis and aortic sclerosis is that stenosis can result in symptoms. It can result in symptoms of decreased cardiac output, but sclerosis is not associated with any of those symptoms of decreased cardiac output. It is rarely associated with the same. Then, certain other rare conditions which are associated with aortic stenosis are type 2 hyperlipoproteinemia, ochronosis and alkaptonuria. Okay. Now, let us move on to the types of aortic stenosis. The types of aortic stenosis are classified based on the level at which the obstruction is present. So, it can be classified as the valvular, the subvalvular and the supravalvular aortic stenosis. So, it is classified as the valvular, the subvalvular and the supravalvular aortic stenosis. Valvular basically means that the aortic stenosis is at the level of the aortic valve. Okay. Subvalvular, where have you heard that? This is nothing but your idiopathic hypertrophic subaortic stenosis. Idiopathic hypertrophic subaortic stenosis, which is also referred to as the HOCM or the hypertrophic obstructive cardiomyopathy. So, this results in a subvalvular or a obstruction below the level of the valve. Supravalvular aortic stenosis is also called as Williams syndrome, where the patient has an elfin facies. So, what is this elfin facies? He has a broad nose, a pinched nose, and there is a long philtrum. And this is what we call as the elfin facies. And the dyselectrolytemia which is associated with that is your hypercalcemia. Okay. So, these are the different types of aortic stenosis. We have a valvular, a subvalvular and a supravalvular aortic stenosis. Okay. So, in valvular aortic stenosis, what is the second heart sound? The second heart sound A2 is soft in valvular as well as subvalvular aortic stenosis. Loud second heart sound is found in supravalvular aortic stenosis. Okay. Another characteristic feature that you have to remember about the supravalvular aortic stenosis is that there is the Coanda effect. Okay. There is this Coanda effect. So, what is the Coanda effect? The right-sided blood pressure is greater than the left-sided blood pressure. So, this is what we call as the Coanda effect. So, this is seen in supravalvular aortic stenosis. So this is what we call as the co-anda effect. So what happens in this co-anda effect is that the jet of the blood which happens during the systole as the blood flows to the aorta becomes directed towards the right shoulder because of the stenosis, and this is what we call as the co-anda effect. So the presence of loud A2, and the presence of this co-anda effect is seen in supravalvular aortic stenosis. Okay, so now we have understood the types and the various features of aortic stenosis. Let us go to the hemodynamics of aortic stenosis. Okay, fine. So the first thing that you have to know, the first thing is that this is the LV, this is the LA. There is a stenosis at the level of aortic valve. So what happens to the cardiac output? The cardiac output is decreased. So what happens to the cardiac output? The cardiac output is decreased. So what happens as a result of this decreased cardiac output? The patient can have syncope. Initially it is exertional, in later stages they can have syncope even otherwise. Okay. Also, over the course of time, because of the stenosis, as the blood is moving towards a high pressure, the pressure gradient is high. What happens to the pressure in the LV? The pressure in the LV begins to increase. Over the course of time, as the pressure in the LV begins to increase, what is the remodeling that happens here? So what is the remodeling that happens here? The compensatory mechanism is that there is development of a concentric left ventricular hypertrophy because of pressure overload. So there is a concentric left ventricular hypertrophy because of pressure overload. Over the course of time, this increased pressure is reflected onto the LA also. So there is an increase in the LV end-diastolic pressure, which further results in an increase in the LA pressure, which further increases the pulmonary capillary wedge pressure. So all the backward pressures are going to increase. The LV end-diastolic pressure increases, which further causes an increase in the LA pressure. Now we know that the pulmonary veins are the ones which basically drain here. So the pressure increases here and in the lungs. So what happens? There can be exudation of fluid in the lungs and there can be pulmonary edema. So finally all of this results in dyspnea. Okay. Apart from that, what we should know is that because of this hypertrophy, now the flow is decreased during diastole because of the hypertrophy. As the flow decreases, the flow to the coronaries is also reduced. So it can result in angina. Okay. So that is about the hemodynamics of aortic stenosis. So because of the reduced forward output, they can have syncope. They can have exertional syncope so because of the reduced forward output, they can have exertional syncope initially. And in the later stages, because of the pressure overload, there can be development of pulmonary edema and angina as well, and there can be development of dyspnea. So that's about the hemodynamics. Okay. Now let us understand the symptoms. So the first symptom which is seen in aortic stenosis is angina, followed by syncope, followed by dyspnea. So you remember this with the mnemonic ASD, right? So this is angina, syncope and dyspnea. So what are these numbers? So when a patient of aortic stenosis develops angina, he has 5 years to live. So the mortality is 5 years. Then with the development of syncope, he has only 3 years to live. And with the development of dyspnea, that basically means that there is already some amount of pulmonary hypertension that has set in and the prognosis is very, very poor. So remember, angina, syncope and dyspnea. Angina is the first symptom to occur and within 5 years, the patient has 5 years to live. It basically means that if the patient has developed angina, the patient has 5 years to live, followed by which there is syncope and there can be dyspnea. Okay. Atrial fibrillation. If a patient of aortic stenosis develops atrial fibrillation, then there will be a very, very poor prognosis. Okay. Hypertension. With the development of hypertension, what happens? Let us see. So, this is the aorta, this is the LA and this is the LB. Now, this is the stenosis and the blood is flowing against a pressure gradient. Now, there is another extra pressure that is applied from here because of hypertension. So, what happens to the gradient? The gradient slightly decreases. So, the development of hypertension can mask the aortic stenosis. So, the development of hypertension can mask the aortic stenosis. Alright. Now, left ventricular failure. Over the course of time, what happens is that the LA and LV can be massively dilated and they can have LV failure, and this is poorly tolerated. Okay. Another very important clinical syndrome that you should remember is the Hyde syndrome, which is nothing but angiodysplasia of the colon. Angiodysplasia of colon associated with aortic stenosis is what we call as the Hyde syndrome. Okay, and there is bleeding per rectum associated with aortic stenosis. Fine. So, I hope you have understood what are the hemodynamic features. So, I hope you have understood what are the hemodynamic features and what are the clinical features of aortic stenosis. Now, let us move on to the signs. So, what is the pulse finding that you will find? The pulse is usually a pulsus parvus et tardus, which is a low volume pulse, which is a slow and a late peaking pulse. Okay. What happens to the blood pressure? Now, because there is a stenosis at the level of the aortic valve and the cardiac output is reduced, don't you think that the systolic BP will be low, right? So, there is a low systolic BP which we call as this systolic decapitation. So, there is a low systolic BP which we call as the systolic decapitation. So, systolic decapitation is seen with aortic stenosis. JVP. In the JVP, something that we should be knowing is your Bernheim effect. So, what is the Bernheim effect? Basically, we know that the JVP basically reflects the waves or the pressure changes happening in the right side of the heart. But sometimes there can be pressure changes or changes in the left side of the heart which are transmitted to the right side and the JVP. So, the JVP changes which occur in response to activities in the left side of the heart is what we call as the Bernheim effect. So, JVP can be elevated sometimes in left-sided pathologies including aortic stenosis. What happens to the apical impulse? Now, here there is a concentric LVH, right? There is a concentric LVH. So, in initial stages the apical impulse will not be displaced. What is the nature of the apical impulse? You have a heaving apical impulse. What is the nature of the apical impulse? You have a heaving apical impulse. That means it lifts your finger when you palpate for it, and it lasts for more than 2/3 of the systole. It's well localized as well. So, this is what we call as the heaving apical impulse which is seen in aortic stenosis. Parasternal heave. Can you have a parasternal heave? You can have a parasternal heave because of left atrial enlargement. On auscultation, what happens to the S1? You can find an ejection clip. What happens to the S2? You can have a reverse splitting. The A2, you can have a reverse splitting. So, the P2 occurs before the A2, or you can have a single second heart sound as well. You can have a single second heart sound as well. Because the pressure difference or pressure gradient across the aortic valve is much higher, the hangout interval across the aortic valve is much higher than that of the pulmonary valve. So, the A2 occurs late. The A2 occurs late and the P2 occurs early. So, they can have a paradoxical or a reverse split of the second heart sound. S3 will you have? No. S4 is a definite in aortic stenosis. Why? Because, so why is an S4 seen? S4 is seen mainly because of the contraction of the atria against a non-compliant hypertrophied ventricle which is seen in aortic stenosis. Alright, so there is a non-compliant and a hypertrophied ventricle which is responsible for the fourth heart sound. Fine. Now, what happens to the murmur? What do you find in the murmur? You find an ejection systolic murmur. Where do you hear it? In the aortic area, which radiates to the carotid. Okay? Which is best heard in the sitting and leaning forward position. With the diaphragm of the stethoscope. Okay, so that is your aortic stenosis murmur. Okay, now what is this Gala-Verdin phenomenon? So this is your aortic area, this is your mitral area, right? So sometimes there can be an hourglass type of radiation which occurs. In severe aortic stenosis. So the ESM is heard as a PSM in the mitral area. This is what we call as the Gala-Verdin phenomenon. So this ESM in the aortic area is heard as the ESM in the mitral area, and this is what we call as the Gala-Verdin phenomenon. Now clinically when you examine the patient, how do you know whether this is a severe aortic stenosis? So these are the features which help you identify that. Presence of a Parvus et Tardus pulse, yes, presence of Gala-Verdin phenomenon, and presence of a single second heart sound are all suggestive of severe aortic stenosis. Also, we know that symptomatically, if the patient has already developed syncope and dyspnea, then definitely he is progressing towards a severe aortic stenosis. Okay, fine. Now let us move on to the investigations. The first investigation is your ECG. Now let us see what is happening in the ECG. Can you see that there are tall R waves in V6 and deep S waves in V1. So there are deep S waves in V1, tall R waves in V6, deep S waves in V1, and if you add this is definitely more than 35 mm. So this is suggestive of left ventricular hypertrophy. Along with T wave inversions in the lateral leads. So this is what we call as the LVH with strain pattern. So what is the strain here? This is what we call as the LVH with strain pattern. So what is the strain here? This is because of the chronic pressure overload state that is seen in aortic stenosis. You can find a strain. Okay, so this is your left ventricular hypertrophy with strain pattern which is seen in the ECG of aortic stenosis. Alright, okay. Now what will you see on the chest X-ray? So whenever there is a stenosis, there can be post-stenotic dilatation. Of the aorta. So this is what we see here. When you see that there is a post-stenotic dilatation of the aorta which is seen on the chest X-ray. Alright. The next investigation would be your echocardiography. On the echocardiography, what are the things that you will be seeing? You will be looking for the aortic valve area. We have already learned that if the aortic valve area is less than 1 centimeter square, then it is definitely a severe aortic stenosis. Then we measure the gradient across the aortic valve. If the pressure is more than 40 millimeters of mercury, then this is a severe aortic stenosis. Then we measure the peak velocity across the aortic valve. If the peak velocity is more than 4 meters per second, then this is what we call as the severe aortic stenosis. Okay. So, the gradient is more than 40, peak velocity is more than 4 and the area is less than 1. This is called as the severe aortic stenosis. Now, what is this concept of low flow, low gradient AS? What is this concept of low flow, low gradient AS? So, what happens, as the name suggests, the gradient is less than 40 millimeters of mercury and the velocity is less than 4 millimeters per second. Then, but there is still a severe AS. There is still a severe AS. So, this is what we call as a low flow, low gradient aortic stenosis, where the gradient is less than 40, velocity is less than 4, but there is severe AS, and this is seen in heart failure, reduced ejection fraction. So, this is associated with heart failure, reduced ejection fraction. Okay. So, in patients with heart failure, if you are finding a aortic stenosis, is it because of the heart failure which is the stenosis is happening, or is it because the aortic stenosis is causing the heart failure? How do you differentiate that? You differentiate that using a stress test. You differentiate that using a dopamine stress test. So, use a dopamine stress test to differentiate whether the heart failure is causing a stenosis in a low flow, low gradient AS, or is it the AS causing the heart failure. So, if you use the stress test, then the symptoms of AS improve in heart failure. Correct? The symptoms of AS improve in heart failure. Alright. So, that is about the echo grading of AS and what is the low flow, low gradient AS. Now, let us look at the management of aortic stenosis. As we all know, as how we have read in the other types, which is your MS and your MR, staging of aortic stenosis is also into 4 grades, which is your stage A, B, C and D. So, A is at risk. So, a patient with bicuspid aortic valve or aortic sclerosis, he is not symptomatic, he does not have AS, but definitely he is at risk. B is mild to moderate, progressive AS, right? So, there is progression of there is a decrease in the aortic valve area, but it is still not severe. Stage C is asymptomatic severe AS and stage D is symptomatic severe AS. So, why should we know this? Is because depending upon the stage, we decide what type of treatment we want to offer to the patient. Okay, fine. Now, let us move to the surgical management of aortic stenosis. Fine. Let us move to the surgical management of aortic stenosis. So, first we see whether there are symptoms due to aortic stenosis. If the patient is symptomatic and the patient is in stage D. So, if it is stage D, that is symptomatic severe MS, where the peak velocity is more than 4 and the pressure gradient is more than 40, then you do an aortic valve replacement. Which type of aortic valve do you prefer? Is it a transcatheter aortic valve replacement or a surgical aortic valve replacement? That we will be looking at with further discussion, right? So, symptomatic stage D, definitely you do that. Then, if the aortic valve is less than 1 centimeter square, that is a severe AS with the Vmax more than 5, and if the EF is also reduced, right? Then if the EF is less than 50%, and then if the EF is less than 50%, then you definitely have to do a surgical or a transcatheter aortic valve replacement. Now, there are no AS symptoms. No AS symptoms means either stage B or stage C. No AS symptoms means either stage B or stage C. So, in stage C, if the EF is low, if the stage C EF is low, then you please go ahead and do a valve replacement, right? Or if the patient is undergoing any other form of cardiac surgery, then definitely you do a surgical valve replacement. In stage B, that means that the patient has not yet gone into severe AS, there is progressive AS, right? So, if there is progressive AS, so the patient has not yet gone into severe AS and there is progressive AS, then if the velocity, peak velocity is high or there is rapid progression of disease, and the low surgical risk is present and he is undergoing surgery for something else, then you definitely go ahead and do a surgical aortic valve replacement. Okay. So, if the patient is symptomatic stage D or symptomatic stage B with low EF, then definitely you do a replacement. Then if the patient is in stage B or C, if they are undergoing any other procedure, cardiac procedures, in stage B if the progression is quite rapid, then you replace it. In stage C, if the EF is low, then you go ahead and replace the valve because they are asymptomatic but the EF is less than 50%, then they will definitely become symptomatic. So, you replace the valve before they move on to stage B. Okay. Now, what are the two methods which are used are transcatheter aortic valve replacement, transcatheter aortic valve replacement. So, we have the transcatheter aortic valve replacement which is known as the TAVR or the surgical aortic valve replacement. Okay. Nowadays, unless the patient is undergoing some major surgery or cardiac surgery, TAVR is what is preferred over SAVR. Okay. So, this can be done by two. This is your balloon apparatus. This is your balloon apparatus which is used for transcatheter aortic valve replacement, and this is your self-expanding stent. This is your self-expanding stent which goes to the aortic valve and dilates it. So, these are the two ways in which your transcatheter aortic valve replacement can be done. Fine. So, this brings us to the end of this topic. We have learnt about aortic stenosis on the whole. We have learnt about the etiology, the clinical features, hemodynamics, and how do you manage aortic stenosis. So, I hope you have understood this session completely. Let us all meet in the next session. Thank you.